the tourniquet, but we have not inflated it, because if you're not going to open it up, I don't think tourniquet is necessary, and we rarely have to open these fractures to reduce it. So we are not anticipating opening of the fracture, but we have applied the tourniquet just in case we need it. I think the first step now will be to identify the entry point for our radius. So the first step is to take any metalwork. In this case, we have used the artery, and take an X-ray of the distal radius to identify the entry point. Now, in terms of entry point, what is the correct site of the entry point? So entry point normally should be around 2 centimeter distal to the physis. That is the usual entry point. The entry point could be dorsal, or entry point could be lateral. Now it's a personal preference. If you are taking a dorsal entry point, you go through the listus tubercle. If you are taking a lateral entry point, you just make a small incision at the site of your preferred choice, do a dissection, and then proceed. I personally prefer lateral because the chances of irritation of extensor tendon is very little. All you need to be careful is to be mindful about superficial radial nerve. So we have checked the position. This position looks good on this particular case because the fracture of the radius is quite proximal. So even if I want to go a bit more distal, or sorry, proximal, I don't think that would matter. However, if you are encountering a fracture of the distal third of the tibia, then try to make this entry point as distal as possible to the physis. But you have to be sure that you are at least 5 mm distal to the physis. So now when you are starting up, I think for junior surgeons who are just taking up their career, it's extremely important that your entry is bang in the center on lateral. If you gain experience, then you can slide your artery dorsal and slide your artery volar and be certain. However, when you are starting up, take a lateral and do a skin mark to identify where you're going to start. So just to explain, we have marked, there is a vertical skin mark, if Dr. Rashid can put there. So that is our site from the physis. So we have marked this on AP, and then again we have taken a lateral, and when we check the lateral, this was the center. Now the point at which these two lines meet, that will be the point at which you are going to make your incision. So just start and make a small incision roughly around 1 centimeter. Don't try to make it too narrow, because you want to dissect it nicely with help of your dissecting scissors and artery, just to be sure that you are close to the bone and you're not injuring the superficial radial nerve, which is the only important structure here. So we're just going to use an artery and do a gentle dissection till we reach the periosteum. Now some people may ask which bone to do first. Now the most difficult bone that you anticipate during the surgery, you should do it first. However, some people will disagree with me, but that is the principle I follow, and it's usually the radius. So I always start with the radius. So next step is that take an awl. Some people will use drill bit, but I would say never use drill bit. Use an awl. It's much more controlled, it doesn't generate heat, and it's much more easy to use. So next step is to make your entry point. So start vertically first and then take an X-ray. So now you can see that we have gone 90 degree to the bone, and that is what you should do, because then you will not skid onto the bone. And then gradually decrease the angle, and I will show you what I mean. So gradually start 90 degree and then slowly decrease the angle, and then try to make it more vertical for your 10th nail to go. And I think we'll just check one more time, and the C-arm images looks really good. So when you are starting up, the most difficulty I see juniors struggling is that they make a good hole and then they struggle to put the 10th nail to find the hole. So the next step is now to take the awl out and put our 10th nail. I think junior people struggle to find the entry point. So one key is that your assistant should be ready to take the awl off, and you should be ready with your 10th nail and be ready to put in the same direction, and that way it's much easier to find your entry hole. So Dr. Kushwant is going to take it out and Dr. Rashid is going to insert the nail at the same time. So once you are happy that you have the right feel, take an X-ray to make sure that you are inside the bone. On this occasion, it looks pretty good. So slowly, with the twisting movement, pass the nail. Now the other question that people may ask is whether do you do the pre-bending or not. And I would say if you want to do pre-bend, it's okay, but I don't usually pre-bend because I feel it's unnecessary. But pre-bending has been advocated by some, and a lot of people have refuted it that there is no real advantage of pre-bending when you're using just one nail. But if at all you are using a pre-bending, just use it for radius because ulna is pretty much straight. You don't need to pre-bend the wire for ulna. So now, as you all know that there is a bend at the end of the nail, and that bend is for you to be used to your advantage when you are negotiating this nail in a tight space. So deliberately, we have kept this curve away from the cortex so that when you push it, it slides away and then follows the track of the medullary cavity. If you put it other way around, you will struggle because it's going to hit, it's going to engage in the cortex and you will struggle a lot. So this is the right way, and then slowly with the twisting movement proceed upwards. So once you reach the position which I showed you on C-arm, then usually it requires little bit of hammering to negotiate the nail distally. So after gentle tapping and bit rotating movement, you can see the wire is now gone distally. This is the point where you need to show some patience because this is the point where you might find some difficulty in negotiating. This is probably the difficult part of the operation. But once it is through now, the rest all should be pretty easy. So after negotiation, you will see you will reach a point where now the bend is towards the cortex. If you continue to hit, it may progress, but then it will be difficult. So all you need to do is to rotate the T handle, and then you will see that the bend is away from the cortex. You can bend a little bit more and then start hammering it, and it will proceed further. So now after negotiation, our nail has gone up to the fracture site, and now it's just matter of reduction and then passing the nail. I think one thing I forgot to tell was, the age limit in which this is indicated. So the lower age limit for using the TENS, most people will say is around 3 to 4 years, and the upper limit is around 13 to 15 years. However, there are certain times where we use it in the adults as well, but the routine age group in which we should be using is from 3 years to around 15 years. So the reduction is the key in getting a close reduction and passing of the wire closed. So we are just applying a ligamento-taxis, so there is a traction and a counter traction. Because it's a proximal third fracture, we have kept the arm supinated, and then we will check the position in C-arm how it looks. So this is how it looks. So still there is some translation. Now we can use the bend of the TENS in order to pass across. At the moment it is, I think, facing this way. So if it turns this way across at this site, then it will follow the medullary cavity, and that way it should reduce or go on to the proximal fragment easily. So now our nail has gone up to the fracture site. So we are going to curve the tip towards the lateral side, and you can see Dr. Kushwant will try to push this fragment slightly medially so that we are able to negotiate the nail into the medullary cavity proximally. So now we have rotated the nail towards the lateral side and we'll hammer it now. So now you can see that because we bend the tip of our TENS nail towards the lateral side, if you can see this thumb of Dr. Kushwant, ideally you should not be seeing it, but he was pushing this fragment towards the medial side, and it looks as if now we are into the proximal fragment. We'll confirm it on a lateral view just to be sure that we are in the right place. So on this occasion, we are fine that on lateral also it looks pretty good. However, if it was looking good on AP and in lateral it was going dorsal or volar, then keep the traction on AP and then reduce the fracture on the lateral. Then you don't need an AP, because on AP you know if you are giving traction the alignment is good. So all you need is to focus on lateral and then reduce it and then pass the 10th nail. It's very hard to explain everything here, but that is the philosophy. So how far to take the nail? On this occasion, we have taken quite far. We have still left a couple of centimeters. This is because when we cut the nail later on, we still have some space for nail to be hammered, because you don't want your nail to be prominent and irritating the soft tissue or the tendons. So now we have passed our 10th nail in radius from distal to proximal. Now we will pass the ulnar 10th nail from proximal to distal. So same way, we want to mark the entry point of the ulna. So it's usually 2 centimeter distal to the physis, and we do the same thing. We mark AP and lateral to see where we are going to make our incision. So this is what I meant. You draw a line here, you are a couple of centimeter distal, and here on lateral you are in line with the ulnar medullary cavity. So again we'll make a small incision with a 15 blade, and then we will dissect with an artery clip, and once we have done the dissection and we are ready to put our awl, I'll be with you. So again, like distal radius, start at 90 degree and then just go slowly and check the position on X-ray. Now the position on the X-ray looks good. So like radius, we are just going to angle it. On this occasion, we are starting proximal to distal. We'll just increase the angle slowly so that we become in line with the ulnar shaft. So gradually drop down your hand and increase the angle like we did in the radius. So not like in radius, one person will take the awl out, the other person will be ready to find the hole and put the 10th nail in the hole. So like in radius, we will use this curve to our advantage, and as you at this point of time the cavity is quite wide, you are going through the metaphyseal area, but once you come to the cortical area, use your bend to your advantage and keep rotating it by taking sequential X-ray as we did in radius. I don't want to reinforce it again and again, but keep changing the direction so as to pass the 10th nail easily. So like in radius, this bend is now hitting the cortex. So as I said, you just need to turn it and take this bend away from the cortex, and then keep either the rotating force or gentle malleting to take it up to the fracture site. So now we have got our nail up to the fracture site. Now as we did in radius, again we are going to apply a longitudinal traction and then take an AP and a lateral view to assess our deformity and to correct it with appropriate forces, and then negotiate the nail into the distal fragment of the ulna. So now we have taken a lateral or an oblique, and this is the AP. We have used the forces in order to neutralize it. The reduction looks okay. Now we will just pass the wire with a mallet, and with it, we will see whether we succeed or not. Now looking at the AP and the lateral, our guide wire is inside. There will be occasions where you have soft tissue interposition, or it's an old fracture, and despite trying, you are unable to reduce it. So there's no harm in making a small incision, opening it up, and reduce it, and proceed with the 10th nail. So now we have passed our guide wire. We have still left few centimeters, and this is because we will cut the 10th nail and we will push it in. So leave few centimeters so that you cut it long and then push it in to bury the nail so that it's not prominent and it's not irritating the soft tissue. So one small thing that most people don't keep in mind is that if you remember this tip, they should face towards the same direction. So if they face the same direction, then it tenses the interosseous membrane, it helps in a good reduction. So if you see, the bend here is facing towards the radius, so it's pointing this way, and here it is pointing towards the ulna. So both the bends should be pointing towards each other so as to keep the the last bit is to bury the tense nail inside, and then it's just matter of putting few stitches. I don't put any plaster after this operation as I feel it's unnecessary. Patient can mobilize from the next day. So you can see this is our skin closed. We have put a single stitch on the radius side and a single stitch on the ulnar side. So you can do this operation by a really small incision. We'll put some dressing and patient will